First, I just want to begin with a couple of disclosures. One is that my lab and my group is funded by the Canadian Institutes of Health Research. I don't have any connections to the pharmaceutical industry, in case anybody's wondering. And secondly, I want to respectfully acknowledge that I'm speaking from Treaty 6 territory, traditional lands of First Nations and Métis peoples. I just want to remind people that HIV is a retrovirus, and there are many retroviruses that infect the nervous system. Those of you who own horses or cats may know that their virus is very closely related to HIV that infect those species. And there are other retroviruses in humans, such as HTLV1, which also produce neurologic disease in humans. I think that's worth keeping in mind because retroviruses are distinct in their capacity to cause neurologic disease. I'll also say a little bit about SIV at the end, because it's hard to study the brain, as some of you may know, and so we're forced to use animal models, and I'll describe a collaboration involving the use of non-human primates. So HIV encompasses a broad range of conditions. Early in the 1980s, opportunistic infections became very apparent, but soon thereafter, people recognized that there were disorders specifically caused by HIV, notably something called HAND, which I'll come back to in a moment, which is a neurocognitive disorder, and DSP, which is a peripheral nerve disorder. But there are other disorders as well. And then more recently, as we've developed new therapies, there have been issues regarding ART-induced neurologic disease. This prompted years ago the thought that we should create a cohort of patients who were followed within the clinics in Calgary and Edmonton in the setting of what we call Champs in NeuroHIV, which is CHR-funded team grant. And I'll come back to that in a few minutes. But important to recognize that this is the disease course of HIV. We initially recognized neurologic disease at this stage, at the later stages of HIV infection, but it's become increasingly apparent, even as we move ART to the at the time of diagnosis, it's also evident that neurologic disease emerges at that time. Nonetheless, there are over 38 million people with HIV globally. About 25 million receive antiretroviral therapy, and then about 70,000 people in Canada. What remains disturbing, though, that approximately 25% of people who receive antiretroviral therapy still exhibit some form of HIV-related neurologic disorder. And that's really concerning. And and just to give you a sense, if you look at the overall global burden of neurologic disease, it's much lower in the general population. It's about 6%. So it's clear that HIV somehow accentuates the emergence of neurologic disease. HIV is a bit different in the brain than it is in the blood and other organs. It doesn't, there are few T cells in the brain. There isn't a resident lymphoid population of cells, but there are cells that are selectively permissive to HIV, notably the brain macrophages, microglia, and also the infiltrating macrophages. So it's clear that HIV does get into the brain. And then when it's there, it causes damage to the brain, usually through inflammatory molecules. The other concern about having HIV in the brain is it obviously leads to neurologic disease, but there's also the potential for ART resistance to emerge because it's a relative sanctuary for the virus. And finally, and more recently, people have shown that there's a potential for rebound virus. In other words, virus in the brain can actually leave the brain and reseed the circulation. That's very concerning. There are a lot of issues that remain to be understood fully. Host restriction factors in the brain remain unknown. The impact of the microbiome, aging, and the sex also are factors that are unclear regarding their impact on viral persistence in the brain. The syndrome that perhaps has garnered the most attention over the last almost 40 years is HIV-associated neurocognitive disorders. Once called HIV dementia or HIV encephalopathy, it's a distinctive syndrome defined by impaired decision-making, often behavioral features, movement disorders such as Parkinsonism, usually in the setting of immunodeficiency and the presence of the virus in the brain. And this can be highly disabling, rendering people unable to care for themselves, unable to work, being socially isolated. A devastating syndrome for people who suffer from it. It's evolved, things have improved substantially with the advent of antiretroviral therapy, but this is actually a very recent paper showing that, in fact, despite ART, the prevalence of hand continues to be approximately 21%. This is a bit lower than is reported in some of the other studies, like the MAC study, some of the other studies from Canada. We were very careful in making sure that we did not include any obvious comorbidities. This is a study from a graduate student who worked with us, and we were careful. The overall prevalence of neurocognitive impairment was about 30%, which is bang on with what the MAC study shows. But when you exclude people with head injury, prior head injury, chronic issues with substance abuse, it drops to about 21%. Nonetheless, that's 1 in 5 people. Devastating for people who are affected. And we looked, using a machine learning approach, we looked at risk factors for the development of hand in this study. The other issue that I'm a neurologist, so I work in the clinic, and the other issue I face daily in the clinic is chronic neuropathic pain as a result of neuropathy. And again, the prevalence is almost 1 in 5, 18%. This is actually fits with settings right across the world in sub-Saharan Africa and elsewhere. These numbers are again about 18%. It's a very trying disorder. It's a burning sensation in the feet and hands. Usually a loss of axons, similar to diabetic neuropathy, and thought to be inflammation driven. For which we don't have any definitive treatments. If I have time, I'll say more about treatments at the end. But there is this overarching concern: what can we do to eliminate viral persistence? And I think, as everyone on this call knows, that we've had antiretroviral therapy since the mid-1990s, and it's very effective at suppressing virus in the blood and improving outcome among people who receive medications in terms of survival. No question, antiretroviral therapy prevents and improves neurologic dysfunction. But existing neurologic dysfunction, such as hand or neuropathy, is not reversed by antiretroviral therapy. May be improved, but not fully reversed. The other thing to keep in mind, we hear a lot about the CPE as a score of efficacy of antiretroviral therapy in the nervous system. It's important to keep in mind that that is not really validated empirically. That's more or less a hypothetical score. And I think Scott Letond, who's the originator, would concur with that view. Nonetheless, ART's impact on the brain HIV reservoir remains unclear. And this prompted us to try to do some mathematical modeling. And we're using both human data as well as SIV data. And we showed that, in fact, we actually had a surrogate measure of provirus in the brain. And that over time, we see there's an accumulation of virus in the brain amongst all people who are affected. The story was much more rapid in SIV infection, probably because the initial inoculum is higher. But then we also tried to model the eradication of virus from the brain, assuming highly efficacious antiretroviral therapy. And in people without hand, it was clear that you could eradicate the virus within a decade. People with hand, it was substantially longer and a little bit disconcerting. Well, very disconcerting, in fact, when you look at these numbers. So that was hypothetical. That was mathematical modeling. So we just tried to test this model empirically. So we actually looked at patients who tragically died from HIV, and we also had uninfected patients. And we looked at the amount of viral RNA, total viral DNA, and also proviral DNA in the brain. People who uninfected, of course, there was no virus. People who were HIV infected were not on antiretroviral therapy at the time of death, and then people who were on antiretroviral therapy at the time of death or had a surgical intervention that permitted us to do a brain biopsy at that time. And in fact, what we saw was, although this is non-significant, there was a slight trend towards a reduction in viral RNA amongst people who were treated, but overall total viral DNA and provirus was actually slightly increased in those people on antiretroviral therapy. Despite this group of patients had completely suppressed virus for upwards of a decade, suggesting while indeed we could control virus in blood, there was persistent viral DNA in the brain, which was, we found this disturbing, and we thought, well, could this be an artifact? So we then collaborated with Jérôme Estiquoyer at University of Laval, who has a non-human cohort of SIV-infected monkeys. And we looked at 3 groups. We looked at monkeys that were infected with SIV without antiretroviral therapy, those that had antiretroviral therapy interruption, and finally those that were fully treated for the duration of the study with contemporary antiretroviral therapy. And I won't go into the details because in the interest of time, but in a nutshell, what we found that was in fact viral RNA, total viral DNA, and integrated viral DNA really did not change in the brain. And we looked in different regions of the brain, and we found that while there was slightly more virus in the deeper regions, the so-called striatum of the brain, than the cortex, but nonetheless, it was pretty consistent across the board. And this group, the antiretroviral treated group, were like our human cohort, fully suppressed for the duration. This group of interrupted antiretroviral therapy had a burst in plasma as well as CSF virus. And so from this, we made several conclusions, which are disturbing, but certainly are an impetus to go forward with looking at new strategies. First, HIV, DNA, and RNA persist in the brain despite effective antiretroviral therapy. Secondly, contemporary antiretroviral drugs really had limited effect on SIV burden, even in the presence or absence of antiretroviral interruption. And then finally, and I didn't show you this in the interest of time, there is a dichotomy. These cells in the brain that I told you about earlier, the microglial cells and the macrophages, are relatively resistant to the effects of antiretroviral therapy. And I didn't have time to show you this, but no doubt this is one of multiple factors that contribute to the persistence of HIV in the brain. So I'm going to stop there. And importantly, my acknowledgements are perhaps the most important part. I have a wonderful group of people in my lab, Naz Mohammadzadeh, who did most of the recent work, several others, Jason Fernandez, who's also a wonderful graduate student. Weston Rhoda did all of the mathematical modeling collaboration with Michael Lee. And then my other collaborators, Sue Champs in NeuroHIV, Eric Cohen, Nabil Seda, Tom Hopman, and Leah Rubin, and Esther Fujiwara. And then, of course, John Gill and Jacqueline McMillan, whom you've heard about a little bit about today already, and also wonderful collaborators in CanCure as well. And I'll stop there. Thank you very much for your attention.